As you may be aware, May is Stroke Awareness Month, so this is a good topic for the time. I'm going to move on into my slides, and what we're going to focus on in my part of the lecture is going to be about general topic of stroke, and then we're going to move into Dr. Zomorodi's lecture where we'll get into some more details. I'm going to cover some of the signs and symptoms, and I think as well he's got some slides on that topic as well. What we'll start with is why we should care about stroke and why it's important. In the time frame that I have gone through medical school in the early 1990s till present, our whole paradigm of stroke has changed from, in the beginning, stroke was basically a disorder which had no treatments and the interventions were nil, to now we have aggressive interventions, endovascular therapy. But perhaps the most important thing we suffer from currently is a lack of patients getting to the hospital in a timely fashion so we can deploy the therapies. So our therapies are time dependent, and so we should care about stroke for a lot of reasons, but one of the focuses of this lecture that we're going to cover is going to be for part of the aspect of the interventions that we have. So when I was in training in emergency medicine, we also developed and FDA approved intravenous TPA, or tissue plasminogen activator, which is the clot busting medicine. So I practiced before we had the medication, and I practiced ever since with the medication, and we've come a long way in terms of ability to provide that and define the patient population that should receive it. We'll talk a little bit about risk factors for stroke, and in that I'm not going to cover a great amount of detail. That could be an entire lecture in and of itself, but that's probably one of the most critical aspects is that 80% of these strokes are preventable. So part of what we can do with the interventions we have now also is better preventative therapy. But again, you have to be an involved participant, as everybody in this room likely is, just by the fact that you're here tonight tells us that you're a little different than many of the patients that we might see. We'll cover some of what we do in terms of the preventative and interventional therapy, and I'll let Dr. Zomorodi cover a lot of that. And in between our lectures, I have some slides that I think are included in your booklet that cover some resources that you can also review, websites that you can go to. So this is a graphic that covers the United States, and I've specifically pulled this from the CDC website. And all of these purple little boxes that you see on the map represent density of stroke as age adjusted per the population. So the darker, the more you see that there's an incidence of stroke occurring in those areas. And of course, this is North Carolina, highlighted here with my basic skills at making these slides. But we're in what's known as the buckle of the stroke belt, which is demonstrated here. So many patients have probably heard of the stroke belt and not been exactly sure what that means. In fact, I don't think that I knew what it meant exactly until I saw a slide similar to this. But this red area demarcates what we call the stroke buckle, which includes Raleigh looking eastward, and then the stroke belt is going to be all of these states here. And that is what you see here, a higher density of stroke per the population. Why is that the case? We're not exactly certain. There's a variety of factors. It may be that there's environmental factors, it may be that there's behavioral factors, dietary factors. They may all play a role. Stroke is now the 5th overall leading cause of death in the United States, but when I started medical school in the early 1990s, it was the 2nd. And it's also differentiated based upon sex at this point. So in women, it's the 4th leading cause of death. It's 5th in men. Now, in the United States, we have about 800,000 people suffering strokes each year. 133,000 deaths occur each year as a result of stroke in the United States, and we're, of course, getting better at that. From 1998 to 2008, the stroke death rate fell approximately 35%, and the number of deaths fell about 19 to 20%, so 1/5 lower over that time frame. Again, you can put this down to better preventative, but also better direct abortive and acute interventional therapies for the stroke as it's occurring. Since most people don't die of the stroke, it's the leading cause of disability in the United States. So there's 7 million stroke survivors as of 2010 in the United States. That number's likely higher at this point. In the context of disability, you see that up to 80% of these things would be preventable through risk factor management. as we discuss here in a little bit in some additional slides down the line. So this is one of the most important health topics for preventative medicine that exists in the United States currently. And one of the easiest things that you can wrap your hands around is that why is it that we still continue to see all of these strokes occurring if 80% of them are preventable? If you had 80% of the airliners dropping out of the sky, I'm sure there'd be something different happening right away. But part of this revolves around, there's two components. There's the patient and the healthcare system. And so the patient has to partner with the appropriate providers to ensure that they're getting preventative care and insist that they work with providers that will support that. I see many patients, and over time you'll see there's certain patients that will come in and they'll constantly have just a slightly elevated blood pressure for which there's no interventions being done. Sometimes I think that that's partly because there's a certain level of denial, but it's also partly because you got to be aggressive with the doctors and make sure you're getting seen and make sure that that's on your agenda. So if we were to ban all smoking in the United States and control everyone's blood pressure, we'd cut the number of strokes in half just doing that. So we don't have to do much to make a change, but it does require partly the patient and the healthcare system and healthcare professionals to work together. Strokes are very frequent. So at the hospital, that's the number one thing that the neurologist, my team, and I will see, along with the neurosurgeons who are doing endovascular neurosurgery, of course, as our primary reason for seeing a patient. Every 40 seconds, someone's suffering a stroke in the United States. So over the next hour, that's going to be several people will have had a stroke as I'm talking and Dr. Zomorodi is talking with you here tonight. When I learned of this statistic, I was quite intrigued by it because it just doesn't make sense that 40% of the population are not aware of even what one symptom of stroke may be. So when they went out and they surveyed just general people walking along the street and asked them, hey, would you consider a symptom of stroke out of these listed things that we have here? There's 40% of people roughly couldn't address even one of those or recognize even one of those. So we have a lot of education to do, such as we're doing tonight. We find that stroke is an important topic for various subgroups. So women in stroke is one that has been aggressively addressed over the last 5 years especially. It's been found that stroke kills more than twice as many American women every year as breast cancer, and as many of you may know, 1 in 8 women will suffer breast cancer in their lifetime. More women than men are dying from stroke, and the risk is higher for women due to a higher life expectancy. But it's also, conceivable at least, that when you have a male population that tends to die at an earlier age, we then see the uptick in women's life expectancy and they're affected by stroke at a higher rate once you drop the male cohort out. Women are going to suffer greater disability after stroke than men, and we're not quite certain why that is yet. There could be a variety of factors: less aggressive intervention, less aggressive care in the prevention of stroke, or a lack of knowledge about how to do so. Blood pressure control, diabetes control is no different in men and in women. It needs to be a priority. And so where we see this stroke surge from age 45 to 54 is felt to be due to unmitigated or untreated stroke risk factors that should be addressed, that could be addressed, but are not being addressed. And so again, preventative education is something that needs to be done. In African Americans, we see an incidence of stroke that's nearly double that of the Caucasian population. And these strokes, and this is my experience as well, will be larger strokes. A lot of these are going to be hemorrhagic strokes, which are going to be bleeding strokes, which I'm going to talk about in a minute. And blood pressure control is a critical component of that, not just in the African American population, but in everyone, but especially in African Americans. I would say that almost every stroke patient I've seen in the last 2 years has hypertension as a risk factor. The death rate is higher because the strokes tend to be bigger. There's a higher incidence of other factors and factors that don't apply to Caucasians, such as sickle cell anemia, that are also at work there. Hispanics and stroke is another area that's one of those hot topics that's being investigated because we're trying to figure out what are the differential factors that may occur here besides just risk factors, education, lack of ability to get the care that you need. But they're also at an increased risk for all types of stroke, which is hemorrhagic or bleeding strokes in addition to thrombotic or clotting strokes, and these are occurring at younger ages. This is more likely related to hypertension and diabetes, but that has yet to be proven conclusively. Certainly, if your primary language is not English and you're in a primarily English-speaking country, your access to care and services will be diminished, and therefore you'll be less likely to have awareness of what to do, where to go, how to get care, and so on. So what exactly is a stroke? Probably everybody in here knows this information, but I'm going to cover it anyway just in case you don't. So we break these things down into two basic categories of an ischemic, which involves a clot either traveling from the heart or part of the arterial system to another location in the brain, or hemorrhagic, which is a rupture of a blood vessel or blood that is released in an injury into a part of the brain where it normally wouldn't be. This results in sudden damage to the brain, and it can result because of a lack of blood flow or a lack of circulation to the areas that are supposed to be served by the blood flow in an area of the brain that is not getting that a stroke, but in areas surrounding the brain in areas at risk for stroke that could be salvaged. Breaking them down further, we see here on the left to you ischemic strokes, thrombotic, embolic, which means blood clots traveling from, say, the heart, and they'll create characteristic deficits that the neurologists, neurosurgeons, radiologists can recognize, which gives us a clue to work backwards from where we're at with what the mechanism of the stroke may be. Hypoxic strokes are actually uncommon, but they do occur with some regularity, and that's basically a lack of blood flow due to low blood pressure in general, which may be an unrecognized phenomenon. So we see some of these strokes in patients who are undergoing hip replacement surgery or having an emergent procedure at an elderly age who were unaware that they had narrowing of the arteries that lead into the brain, which then results, once they're getting anesthetic and they become hypotensive or their blood pressure drops as we induce the anesthetic, they have a relative lack of blood flow, which if it wasn't recognized in time could result in some ischemia, which could result in stroke if it lasts long enough. So these could be reversible, but you have to know that it's occurring and that it's happening. Hemorrhagic strokes are further broken down into subarachnoid hemorrhage, which is blood outside of the normal area of the brain, not within the substance of the brain itself, which can cause pressure on the brain or surrounding structures, can result in other injuries such as seizures, for example. And then intracerebral hemorrhage is what it sounds like, intra being within the brain. You don't necessarily have exclusivity in these, but this general category follows. So intracerebral hemorrhages can become subarachnoid hemorrhage or be associated with it. So it doesn't have to be that it's all one particular type of mechanism. But as you can imagine, the type of stroke you're having is going to predict the type of therapy we can do. Stroke symptoms is probably the most important thing that we could talk about. There are a variety of things that you can easily see here. These are all sudden things that are going to happen, which helps the neurologist and emergency physician seeing the patient sort of differentiate those from, say, chronic problems, which may be neurodegenerative disease and so on. So whenever you have a stroke, it's usually a sudden phenomenon. Within minutes to moments of the onset, you've got a symptom, and it's usually a lack of ability to do something. So we speak in terms of positive symptoms in neurology, such as I have a headache, I've got a problem with a seizure, I have bright spots in my vision, as opposed to negative symptoms, which are I'm unable to communicate, I'm unable to see. Stroke patients can have headaches, especially hemorrhagic strokes may present with that, and that may be the only symptom of some of those strokes. But it's going to be differentiated from a chronic migraine, for example, by how fast it comes on. So we speak in terms of these types of headaches as thunderclap headaches that comes on like a bolt of lightning and can be extremely intense. The patient can't find a position of comfort. So in thinking of a way to educate the public, various organizations have come up with mnemonics, and one of them is, as it's shown here, FAST, which stands for face, so you ask the person to smile, and if they have an abnormal smile which is asymmetric, that's a sign of a stroke. arm, which is where you ask the patient to raise your arms, and if they're unable to do so and unable to keep their arm up, such that one drops, that's a sign of a stroke. Speech is just asking the person to repeat a simple sentence or tell you a sentence, and if their speech is not clear, that should alert you immediately that there likely is something wrong. Most commonly is going to be a stroke. Time is the critical component, because if you have any of these aforementioned symptoms, the sooner you get to health care, the better outcome is going to be. To add to that, another group has designed another mnemonic, which is fast, but it's be fast, and so they added balance in the eyes. So incoordination or dizziness is one of those things that's an often missed variant of stroke. Even healthcare professionals, emergency physicians have a hard time diagnosing these strokes. So if you're having sudden onset of vertigo, that can be the only symptom of a stroke. And vertigo simply is I have a sense of motion of myself or the room spinning around me. Now, it may be associated with imbalance, so I can't walk straight. But what else mimics that? It could be that it's a peripheral nerve problem, such that you're having an inner ear disorder. But even the doctors don't have a great way to differentiate those things. So in most centers, that type of person will get admitted to the hospital and have urgent evaluation. But you have to know to bring that to the attention of the provider. I saw a woman in the clinic just today who's had dizziness that's improved over the last 4 weeks, but came on all of a sudden, who we already know has had several strokes, but did not seek evaluation immediately. Eyes can be a loss of vision. So remember, we talked about bright white lights or speckles. Those are positive phenomena typically seen with migraines, but with strokes you get a dimming or darkening of the vision, or a hole in the vision, which is black. Transient ischemic attacks are sometimes referred to as mini strokes, although we're trying to move away from that moniker. But a transient ischemic attack is a transient, as you might imagine, a limited time that you have symptoms that come and go. It's a warning sign of a future stroke that's often unrecognized. At Duke Raleigh Hospital, all of these patients will typically be placed in observation to get an expedited workup if such has not recently been performed. Up to 40% of patients who have a transient ischemic attack go on to have a completed stroke. A person who has a TIA is almost 10 times more likely to suffer a completed stroke as someone who's never had a transient ischemic attack. The symptoms can be the same, they're just evanescent, so they come and go. The typical duration of these symptoms is 10 minutes or less. So I tell patients any symptoms that you think are not normal, and they last any length of time, even if it's 2 minutes, 1 minute, 30 minutes, those are things that we need to act on right away. I wouldn't advise waiting around to see if they're going to go away, because that's a common reason we don't have the ability to treat patients who are in the midst of having a stroke. So 10% of the patients that have a TIA will have a stroke that's completed within the next 48 hours, which is why we don't typically send those patients home. Every now and then you'll have someone that just doesn't want to come into the hospital, but we try to recognize that and get them expedited follow-up. In some centers you'll have transient ischemic attack clinics, but what happens is that we don't know when this is going to happen, that you're going to convert from a TIA to a stroke, or if it's going to happen. So typically we want to get the workup done before you leave the hospital, because we'd like to know what the mechanisms are so that we can begin treatment now rather than, say, 48 hours later. So there's some perceptions here of myths and realities that I put together. The myth that stroke is not preventable, when 80% of these are preventable. Stroke cannot be treated, which used to be true, now is not true. It requires emergency intervention, so immediate recognition, no delay in onset to calling 911 and getting to the hospital. Stroke only affects the elderly, which is clearly been shown not to be the case. You can be a fetus and have a stroke in utero, which we wouldn't recognize necessarily, of course, but neonates have strokes, and adults have strokes. Children have strokes. 20 to 25% of strokes are in patients under the age of 55. Stroke recovery takes about 6 months. Stroke recovery takes a lifetime, and for most patients, they won't know the length of the extent of their deficits until around 18 months. But even after that, there's a possibility for improvement. What's the cost of all of this? So for the United States, the estimated direct and indirect cost in 2010 was $74 billion. The mean lifetime cost of a stroke per person is about $140,000 in the United States. These costs are going to exponentially, logarithmically increase. So it's projected that these costs will reach $140 billion by 2030. So I've harped on this several times because I want this to be something that you focus in on, but risk factors are a category of things that there are two types of, things you can do something about and things you can't. So we tend to try to get the patients to focus on things they can do something about, which are called modifiable risk factors. And then the things that we can't yet do anything about, such as genetic factors, environmental factors, may in the future be approachable. So we do studies on genetic factors. We had a study that we were doing probably 3 years ago at Duke in Durham, as well as here at Duke Raleigh, where we were enrolling patients, particularly African Americans with stroke, to look for these genetic factors that may indicate a higher risk. So what are the modifiable risk factors? The big five would be tobacco use, if you smoke, stop smoking, blood pressure, control, diabetes needs to be controlled, cholesterol needs to be controlled, and in some patients you'll have obesity, lack of exercise, which you can put in the rubric of metabolic syndrome. There's other factors on here that you may or may not be able to control. So know your blood pressure and have it checked routinely, at least annually. I would recommend doing it more frequently than that. Stroke can happen at any time, but it tends to occur most commonly in the early morning hours between 6 a.m. and noon, because that's when our blood pressures are the highest. So if you're going to measure your blood pressure, you don't want to take all of them in the morning, because your average is going to be an average that's higher than what it probably would be. It's going to be the lowest in the middle of the night when you're asleep. So you should check it several times during the day in several circumstances, always checking it in the same arm, always checking it after 10 minutes of inactivity or being seated. Find out if you have a condition known as atrial fibrillation. That is actually being advertised, I think, extensively in the commercials that I'm being seen, because there's a variety of new oral medications that help to anticoagulate or prevent clotting of the blood that help reduce the risk of stroke. So if you have atrial fibrillation just by itself, you're at 5 to 6 times the normal risk, regardless of your other factors, of having a stroke. And this is an undertreated, underrecognized condition. We're still working on how to monitor for that. So we monitor patients routinely in the hospital with cardiac monitoring, but what we find is that we've not gotten a way within that short period of time to catch all these patients. We missed most of them. So there are implantable monitors now. There's prolonged monitoring. I routinely will send patients out who we don't have a clear mechanism now with 30 days of a heart monitor worn externally, which picks up another 20% of the patients we might miss. If you smoke, of course, stop. If you drink alcohol, do so in moderation. That's usually defined as 2 or fewer beverages per 24-hour period. Know the cholesterol number is not such a factor in the modern paradigm as is your cholesterol elevated or not, and if it's elevated, treat it. If you're diabetic, follow the recommendations of the provider, but make sure that you're seeing someone that's aggressive at helping you to manage that condition. I think all of the healthcare professionals that I know have seen some patients who want to do something more aggressive with their blood sugar, but feel like that's not something that's actually within the realm of their ability to do. So you have to have someone that's willing to work with you. Logging your sugars and constantly showing that they're high and then not doing things about it is not helpful. Diet is a key factor in this, so it's important not to just rely on medicine so much as rely on factors that you can control with your diet, which helps to control your sugar. Exercise is probably the most important thing. So if we see someone that has a stroke and we want to prevent a second stroke, just by increasing exercise, which is defined as 30 minutes or more, 5 or 6 days a week, in which your heart rate is 60% of your maximal predicted heart rate, just doing that is an absolute risk reduction in stroke of 65%. Taking aspirin has a relative risk reduction of about 16% in having another stroke. It's better than managing blood pressure, but it goes along with controlling your sugar and controlling your blood pressure. When you exercise, you also lose weight. You don't need to add any salt to your diet in the United States. There's more than enough salt in most of the food that we have to eat. And then if you have circulation problems, work with your professionals on how to improve that. Typically that involves all these other factors that we've discussed, but exercise being a key one. So again, we mentioned earlier that when you have a stroke, there's a period of time where there's a smaller area of the brain that's usually affected. It's the dark area here, which is surrounded by a lighter colored area, which is called the penumbra. And in that area, we have salvageable brain tissue, but only for a period of time. So in essence, the sooner you get to the hospital and the sooner we deploy a therapy if it's applicable, the smaller the area that's going to be damaged. So in the old days, which is before the era of clot busting medicine, we would just be along for the ride, so to speak. You'd have a stroke, it would be as big as it's going to get, and that's it. The areas around the stroke would not be salvaged, and so the stroke would be larger than it otherwise would be, which is one of the reasons that we see more people living with disability from stroke now than are dying from stroke, because we're pretty good if we get patients in time at salvaging some of these areas that otherwise would be unfortunately lost within the stroke. So this is from an article that was in the Journal of Stroke probably 2 or 3 years ago now, where they try to quantify what actually happens in the brain with the neurons during the stroke. So in a typical what we call large vessel, which means there's a large branch of the arterial circulation, which Dr. Zomorodi will touch on briefly in his portion of the lecture, when you have a clot that occludes or blocks an artery, you're going to have 120 million neurons, 830 billion synapses, which are the connection between all of these neurons, or 447 miles of myelinated, which is insulated nerve fibers, lost each hour. Each minute you lose 2 million neurons, 14 billion synapses, 7.5 miles of myelinated fibers are destroyed. So what does this effectively do? It ages your brain right away. So you're going to age 3.6 years, so to speak, for each hour without treatment. So if you have a large stroke, you might have aged over a decade or more when you leave the hospital. So we see a lot of patients after stroke having cognitive problems, having other deficits that even amongst the immediately recognized symptoms are going to impair them a lot more than they realize as they move on in time. Why is it that we can't treat people fast enough? Well, patients don't necessarily respond, so we want to do these therapies that we have right away, and we probably haven't done as good a job as we should have in getting the message out. We're getting better, but we need the patients to know, which is one of the reasons we do something like this, so that we can educate. But you may not recognize the symptoms. And again, if I'm in the hospital and someone says, well, what should I look for next time? You could look for the same symptoms you had, but that may not be what you come in with another stroke. So again, the symptoms I elaborated upon earlier would be things that should prompt you to seek emergency evaluation, even if that's not what you had before. Denial is a common one. We often see men being brought in by their wives after they get home, and the men have delayed coming in, for example, because they think that the symptoms may go away, or they don't want to bother anybody, they don't want to come in. Think nothing can be done, I think, is becoming less common. Worrying about the cost is becoming more common. If you call the ambulance to be brought in and you turn out not to have a stroke, there's charges that may be levied for bringing you in on an ambulance, for doing all these acute interventions, for doing expensive imaging. So cost does play into that. But I don't want you to worry about it. If you're actually having a stroke, the goal is to see you as soon as possible and treat it. Fear or don't trust hospitals could be a factor. It's more of a factor in certain demographic groups. For example, Hispanics that don't speak English may have a fear of coming to the hospital for fear of having legal action brought against them, for example. I ran into that in Texas years ago. So if you think someone's having a stroke, just dial 911. If you come in on your own or have someone drive you in, you're half as likely to get acute interventional therapy or clot busting medicine than if you come in by ambulance. If in Wake County and larger other metropolitan areas all over the U.S. now, we have a well-vetted system of care. So if EMS may even bypass a hospital that's close to you because they can't provide interventional care or don't have the resources available immediately. For example, periodically our CT scanner will be shut down. We can't see patients. We notify EMS. But if you drive yourself to the hospital and then we have to transfer you to a different hospital, you're wasting time. So by calling 911, you activate a robust system that is going to know all of the various hospitals, all of their capabilities, and their abilities to provide that care, whether it's possible or not, on a day-to-day, moment-to-moment basis. How about stroke recovery? 10% of stroke survivors are going to recover almost completely. 25% recover with minor impairments. Those are actually good statistics. 40% experience moderate to severe impairments requiring special care. That's not so good, but we're getting better. 10% require care with a skilled or other long-term care facility. And those are devastating strokes, as you can imagine. So the fact is that 1 in 10 people are going to have that kind of impairment. And we're getting better at reducing that because if we recognize and treat the strokes earlier, we have less of those larger areas of the brain that we could salvage being involved with a completed stroke. So it's also a myth that most people die from the stroke. You don't die from most strokes. Most patients will not die from the stroke. What they die from is complications from the stroke or other factors that are associated with this, such as getting an infection, blood clot in their leg. In some instances, with large strokes, family may decide to withdraw care simply because the patient had a desire before they had elaborated on that with their relatives that in certain circumstances they simply don't want to have care that may be perceived as, to them, as futile or result in them with significant impairments that they would not want to live with. So 2 more slides. These are going to be resources, and again, these are in your booklets, I believe. But these are associations that both the providers as well as healthcare professionals of all sorts, and in addition, patients use for resources. So you'll find on all of these resources for patients, resources for healthcare professionals that you can access to get more information. So at this point, I'm going to turn it over to Dr. Zomorodi so that he can provide us with some more education on stroke treatments.
How are you all doing? Thank you for giving us the opportunity to present this material to you. This is very important information, actually, to elaborate on some of the statistics that Dr. Peterson gave you guys. In a survey done in 2007, less than 20% of North Carolinians knew the signs of stroke and knew to call 911 at the first sign of a stroke. So I hope already everybody in this room is very comfortable with the FAST or BFAST, and please go ahead and disseminate that to your friends and relatives. We are in the buckle of the stroke belt. Every 2 hours, a North Carolinian dies from stroke, and we have someone in this state get admitted to the hospital every 4 minutes with a diagnosis of a stroke. So friends, neighbors, relatives, so the more you can get the word out about the symptoms and the treatments, the better. And our state, actually, that graphic that Dr. Peterson showed, that was mortality from stroke. So you're very likely to die in this state from stroke. And we're fighting to try to change that trend by having these kinds of events. So Dr. Peterson gave you a lot of data about stroke. Let me give you the neurosurgeon's perspective on this. Okay, we're talking about the brain, right? The brain is an organ that's roughly about that big. It consists of 100 billion neurons. Now, my wife, who is a graduate of UNC, insists that females who come from UNC have more of these neurons than men who come out of Duke, but I'll let you be the judge of that. At any rate, 100 billion neurons packed into this little space. It's about 2% of your body weight. And these 100 billion neurons are connected to each other in special ways, and they're connected to your body in special ways. So these neurons are spread amongst 2 cerebral hemispheres, a right and a left cerebral hemisphere, and those 2 hemispheres sit on top of the brain stem, which is attached to your spinal cord. And so that's how the signals and the ideas and thoughts that you have get turned into actions and communicate with your body. The cerebral hemispheres themselves, we call these the cerebral cortex, They have specialized functions. The left side of the brain is the dominant brain for the vast majority of people. And each of these hemispheres is divided into several lobes. You have here the frontal lobe in purple from this old anatomy slide, and it runs right up to this deep groove in the brain. And then behind that you have this lobe called the parietal lobe. At the very back you have this little wedge-shaped structure, that's your occipital lobe, and then this thing which looks like the glove on a mitt is your temporal lobe. Now I said the left brain is your dominant brain, and the reason for that is because it serves your language function. So let's look at what each of these structures does. At the very back you have the occipital lobe, and what that does is it decodes visual information. So this is how we see the world, turn it into electricity, and then figure out what we're looking at. At the front here, basically it does the 3 Ps. This is your personality, problem solving, and planning behavior. That's sort of towards the front here. And then as you come back, just before you get to that groove, you have what's called your motor cortex. And just behind that groove, you have what's called your sensory cortex. And the interesting thing about these parts of your brain is that they're organized in a very special series represented as the homunculus. So basically your body is represented functionally on these 2 strips of brain in a pattern that looks very much like this guy here. So if during surgery, if I take and put an electrode and stimulate right around here, actually this large area right around here, I'll get your face to move. If I come up a little bit higher and stimulate, I'll get your trunk to move. If I come just a little bit higher than that, a very large area in humans controls the movement of your hand. And then if you come over the top here and go down the middle and I stimulate there, I'll get your legs to move. So the motor area is this portion and the sensory area is the portion right behind it. So if I stimulate these areas, you're going to feel tingling or different sensations in those same parts of your body. And then down here, on both sides of your brain, at the tip of the temporal lobe, is basically emotional processing and memory processing. So this is one of the parts of the brain that gets affected in Alzheimer's disease and starts to deteriorate so people can't form memories. Now, also on both sides of the brain, roughly in this area, is a specialized structure that helps you decode sound. The sound that hits your ear gets turned into electricity and gets represented on this part of the brain. The special thing about the dominant side of your brain is you have a little structure just behind that decodes language. So instead of people talking and sounding like one of the adults on a Charlie Brown cartoon that just sounds like a muted trumpet, you actually hear words and understand what those words mean. And then just in front of that structure, near the part that controls your face movement, is the part of the brain that turns your thoughts into language. So this is the structure of the brain. It's very amazing. It's incredible what it does. And in order to do all of this stuff, it needs a whole lot of blood. All right? I said it accounts for about 2% of your body weight, but it takes up 20% of your heart's output. So every beat that your heart makes, 20% of that blood goes up to the brain to sustain these structures. And the way that that blood gets to where it's going is through this very complex network of blood vessels. And the type of stroke that I want to talk to you about, these ischemic strokes, they happen because one of these blood vessels gets plugged up and blood doesn't get through it, and the brain that depends on that blood starts to die. And this is why things like FAST make sense, because they're very stereotypical things that a person can't do. Before we look at that, let me just show you how we study these blood vessels. This is a diagnostic angiogram, okay? This is where I put a catheter through your leg and drive it up into these blood vessels that supply your brain. So you have 4 big blood vessels that supply your brain. You have 2 carotid arteries in the front and 2 vertebral arteries in the back. When I put a catheter into your right carotid artery and I inject some dye to turn it black and I take an x-ray, this is what you'll see. This is what the camera looking at you face on. This is what the camera looking at you from the side. So on this picture, your eyes would be roughly right here and right here. We're only seeing the right side of your brain, the right hemisphere of your brain light up because only the right side of your carotid artery is getting the dye. So that artery comes up and you can see this beautiful network of blood vessels that it branches off into, and how these branches manage to supply basically the entire volume of the front of your brain. You have this large vessel on the side. This is called your middle cerebral artery, and you'll see it here. It basically gives you the largest supply of any blood vessel. It runs along the length of the entire side of your brain, from the front all the way back to the occipital lobe of your brain. So that's this guy here. Then running along the middle, between the two hemispheres of your brain, you have what's called your anterior cerebral artery, and that just supplies that middle surface of your brain. In the back, when I put a catheter inside those vertebral arteries, again, this is the camera looking at you face on, this is the camera looking at you from the side, you see that the vertebral artery comes up here, joins with the one from the other side, and forms this large blood vessel, which is this thing right here, that runs in front of your brainstem and comes up to the top of your brainstem and gives all these branches that go to your cerebellum, which controls your balance and movement, and a portion of your occipital lobe, which does your visual processing. So just based on this little bit of information, you can figure out how a stroke causes the symptoms that it does. So here we're looking at the brain from face on. I've made a slice through it right along that motor cortex. This is that homunculus, or that funny representation of your body along the brain surface. This area is supplied by the middle cerebral artery. This area is supplied by your anterior cerebral artery. So if we go ahead and knock out this blood vessel and damage all this brain, you're going to get what's called an MCA stroke. Your arm, which is up here, is going to get weak, and this is that A in fast. You're not going to be able to hold your arm up. Your face, which is down here, is going to get weak, and so you're going to get drooping on the side of your face. This is the F. And aphasia. So aphasia is problems either composing or understanding language. And based on that previous slide I showed you with the decoding of sound and decoding of language, you can figure out why that would happen on your dominant side. So you're not going to understand words, you can't make a sentence, right? And that's the S in fast. So this is what a facial droop is going to look like. We've asked this guy to smile. He's able to move the left side of his face, but not the right side of his face. And so that's hanging down. And the interesting thing about the brain is each hemisphere controls the opposite side of the body. So when you see this picture, you got to think to yourself, oh boy, this guy is having a left middle cerebral artery stroke. This is likely his dominant side of his brain, so he's probably not going to have the ability to understand language or create language. This is what the arms would look like. So you ask a person to hold their arm straight up. The weak arm starts to drift down. So this person is having weakness of the left arm. So you say, well, that sounds like it might be a right middle cerebral artery stroke. And then finally is the aphasia. They can't speak or they can't understand. You tell them to do something and they just look at you, or you ask them to repeat something and they can't do it, or when they spontaneously speak, the words don't make any sense when they're put together. So that's fast as it applies to the middle cerebral artery. Here's what happens when you knock out the ACA, okay? So basically, based on this anatomy, you guys are all budding neuroscientists now, you'd expect just the leg to get weak, right? So you knock out the anterior cerebral artery, you're going to kill this portion of the brain. So the leg is going to get weaker than the arm. The leg is going to be number than the arm. And because the anterior cerebral artery takes that whole medial surface of the brain from the front to the back, you're going to get some of that frontal lobe syndrome. So you're going to have some confusion with that as well. This is what it looks like when you hit those branches of that posterior circulation, or the vertebral artery. If you knock out the posterior cerebral artery, you get blindness in the opposite part of the world. And if you knock out the portion supplying the brainstem and the cerebellum, you're going to get some balance difficulties, unsteady gait. So this is the B portion of the BFAST acronym. And you're going to have difficulty with moving your eyes. So eye movement. So that's where BFAST comes from. Okay? So this is how strokes develop. So in all these pictures, what I've showed you is you block a blood vessel, you kill the brain. So you might be thinking, wait a second, so it doesn't sound like there's much you can do. Well, actually, there is something you can do. And there's a little sort of a metaphor I came up with, and follow me on this if you can, and tell me if it doesn't make any sense, to explain what we mean by the penumbra that Dr. Peterson spoke of. So suppose you have a farm, and it has this very well-developed irrigation system, and you plant some plants on your farm, some crops. And these crops, they do really well, they flourish if they get, let's say, 100 gallons a day. If they don't get any water after a day, they'll die. If you give them 50 or 60 gallons, well, they'll gradually yellow and they'll gradually wilt and they'll gradually die. But you have some time. Now, suppose you knock out one of the main channels of your irrigation system. Basically, this entire region here now is going to go from getting 100 gallons a day to getting nothing a day. So this is going to be the core of the death, and this is what we call the core of the infarction in your brain. Okay, so this is the area that goes from exactly what it needs to nothing at all, and it's going to die. But because you have such a well-developed irrigation system, there's this little boundary area where these crops, instead of getting nothing, they get, let's say, 50, 60 gallons a day, right? So now you have some time to fix this problem and try to save these crops. And that's where I come in. My job is to open up the blood vessel and save as many of these neurons that are sitting next to your infarction as possible. And like Dr. Peterson said, time is of the essence. Every bit of time that goes by is a couple million neurons that you're going to lose. And you don't have all that much to spare. So that's why we come in and we do this. Now, if I take too long, or if it takes too long to get you to me, and I go in there and I try to do something to open this up, another problem can happen. The blood vessels in this area that have infarcted will also be dying. So if I go in there too late and I open up the main valve down here and start pumping blood into these blood vessels that have died, they're going to start bleeding all over the brain. And so you can turn an ischemic stroke, where you've just lost some brain cells from a lack of blood flow, into a hemorrhagic stroke, where all of a sudden you have this expanding bleeding area inside the brain. And that's a problem because your brain is in a very tight box. It's not going to have room to accommodate this expanding hematoma. And suddenly you can turn a stroke that could have just left a person with weakness in one extremity, for example, and turn it into something that can cause them to die, because there's too much bleeding inside their brain. So that's the other reason why time is of the essence. Now, based on what I showed you earlier, you guys can probably recognize this. So this is a picture of an angiogram where we're looking face on at a patient, and you can see the carotid artery, this is that middle cerebral artery, and this is that anterior cerebral artery. This is what it looks like when you have a stroke, an embolic or a thrombotic stroke. You basically form a clot inside the blood vessel, and nothing gets by it. And in this case, this person is especially bad off, because not only have you lost one blood vessel, you've lost both of them by knocking out the main trunk. And especially in this situation, time is of the essence. Good news is we now have the technology and the skills to take this and turn it back into this. This is actually a patient who presented to us at Duke Raleigh starting out looking like this, and we treated them and got this result from it. So what is the techniques that you can use? Well, one of the devices that has had the most revolutionary impact on our management of stroke is this device right here. It looks like this. It's called a stent retriever device. Basically, it's a rolled up a piece of metal that you can constrain inside a catheter, and you can put it right onto the clot and pull it out. And I have a little animation for you here. Let's see how this is going to work out. But so you're looking at a person, here are the blood vessels going up to the brain, and you zoom in, and let's say they've had a clot come up into one of these blood vessels. So the first thing I do is I take a little wire and I bring up a special catheter that's got a balloon on the end of it. And with that catheter, what I can do is I can stop the blood flow. Then I can take that wire and go across that blood clot. And once that wire is across the blood clot, I can bring another catheter up and push it across that blood clot. And through that catheter, then I can deliver that. I'm going to just speed it up a little bit here. So here comes the stent device. So I bring it and push the stent so that it's the distal end of that stent is beyond the clot. And then I back up the catheter. And as I do, the stent's going to open up. Now, the thing about the stent is once it opens up, it actually restores a bit of blood flow through the clot, because it forms a little channel inside the blood clot that allows some blood to start getting back to the brain and start delivering oxygen. And the other thing that happens is after a few minutes, these little cells of the stent will expand through the clot, and now the clot is going to stick inside the cells of the stent. Then what I do is I bring down that other catheter that had the balloon on it, and I blow up the balloon so that no more blood is flowing in this direction up into the brain. I start aspirating through that, and I pull the stent and the clot back out of the brain. And that's how we're able to restore the blood flow. Sorry. An alternative to that is this other device which is on the market. This is a catheter that you just take up to the proximal end of the clot, and you hook the end of it to a vacuum cleaner. And it starts sucking on the clot, and then you move these little wires in and out to mechanically disrupt the clot and pull them out of the patient's brain. So we have had tremendous success using this technology, and we've worked out a lot of the kinks to be able to get our whole team, the emergency room physicians, the intensive care unit doctors, the nurses, the technologists in the cath lab, everybody on the same page, so we can take a patient from the door of the hospital to the cath lab and do this procedure on them as quickly as possible. And this is a guy who came to us with this. Basically, again, this is that internal carotid artery, right? So you're expecting to see all these branches come off of it, but you don't. And he came to us just towards the end of the window of opportunity we had to treat them, okay? That window after which the chance of causing a bleeding starts to go up, and this procedure is no longer a good idea. But because we had the system so well set up, it took us 17 minutes from when he got to the emergency room till we pulled out this clot from inside this artery and returned it to looking like this. All right, which is a lot of people working together to do this, but it pays dividends. So this is a guy who worked as a carpenter, had a business where he would install decks for people. He came in completely paralyzed on the left side of his body and losing consciousness, and we did this. And 6 weeks later, he came to clinic, and he was back at installing decks. So it's a beautiful thing, it's a beautiful time that we're living in, and it's great results that we're having. This is some of the data that shows basically if we give you a clot buster alone, your chances of being functionally independent is 35%, but if we combine it with this technology, we can get your chances to be over 60% in some cases. And the faster we do it, the better. But step one begins with y'all recognizing what the symptoms of a stroke are and call us and get to us as quickly as possible so that we can offer you this treatment.